Good afternoon and good evening, and thank you for joining us here for the latest iteration of the Center for Global Health's seminar series about building effective global health partnerships. This afternoon, we're joined by Dr. Megan Robarczek, who will be speaking about her partnership and lessons learned from her certificate program in emergency medicine. Dr. Megan Rybarczyk received her medical degree from the Johns Hopkins University School of Medicine and completed her residency training in emergency medicine at the Boston Medical Center, serving her final year as chief resident. She completed her global emergency medicine fellowship at the Harvard Brigham and Women's Hospital program with a focus on emergency care system development and emergency medicine training. Her experiences in the field of global health have involved clinical work, research, and education all over the world, including countries such as Bangladesh, Botswana, the Dominican Republic, Congo, Ecuador, Ethiopia, Haiti, Honduras, India, Pakistan, and South Africa. Her research and academic interests are currently focused on emergency medicine education and training, particularly in low resource settings. She currently serves as the academic program lead for the certificate program in emergency medicine in Pakistan and Bangladesh, and she is an assistant professor of clinical emergency medicine here at the Perelman School of Medicine. And with that, I turn it over to Megan.
Thank you so much, Alejo, for that very kind introduction. And hello, everyone. Thank you so much for having me here today. It really is an honor to be here with you all, albeit virtually. As Alejo said, my name is Megan Robarczek, and I am currently the Global Emergency Medicine Fellowship Director, the PGEM Fellowship Director here at Penn. And before we get started, I do just want to thank Dr. Galton, Megan, Alejo, and others at the Center for Global Health for the invitation to speak here today, as well as for the Center support for developing global EM here at Penn. And so today in this Global Health Partnership series, I really am excited to talk with you about the lessons that I have learned, as well as the lessons that we have learned in this partnership for the certification program in emergency medicine, or Cpem, how I'm going to refer to that going forward. So before we get started, I do have no disclosures to speak about. I am going to be potentially mentioning several online resources and tools that we've used for the program. I don't have any conflicting relationships with any of the companies or institutions. And then additionally, you may see some photos throughout this talk of individuals without masks, and those are of activities that really took place prior to the pandemic. Now, first, before I talk about the program and the partnership that created the program, I want to talk a little bit about emergency care systems. So this is an essential infographic by the WHO that everyone, not just those interested in global emergency care, should really be familiar with, because it really highlights the fundamental components of any emergency care system and really any kind of healthcare and hospitals system in any setting. And in recent years, there's really been a shift to thinking more about emergency care with the systems approach, rather than the kind of traditional siloed approach of, EMS, emergency medicine as a specialty, different levels of healthcare facilities and all of that. And really, given the interconnectedness of the scene, transport, the different levels of facilities that you have in a healthcare system, you really can't build up one without the other, or really have much of an impact on one or the other without really thinking of it as a whole system. So it's really imperative that we approach the field of development, specifically in emergency care, in this way. And I would argue that the field of emergency medicine in particular really has the right training and the right expertise, and therefore the responsibility to advocate for this approach, the systems development approach, and to really take a leadership role in developing not just the specialty itself, but the system. And so why is this important? Every 6 seconds, someone dies from trauma. TB, HIV, malaria combined cause about 3 million deaths per year. Trauma and injury cause about 5 million deaths. And I can really only see this going up with all of the conflicts throughout the world, as well as the spike in gun violence in our own country in the last couple of years. And now you could say the only reason why deaths from HIV, TB, malaria have declined is because of huge investments from organizations such as the Gates Foundation, PEPFAR, all of that. But then shouldn't we also be devoting the same number of resources, if not more, to trauma and injury? Additionally, TB, complications of HIV, acute malaria, these in addition to trauma, exacerbations of non-communicable diseases, all of these are regularly addressed in the emergency care system worldwide. So instead of focusing on individual siloed disease processes, shouldn't we instead be focusing on the system that could potentially have the greatest impact on morbidity and mortality overall? In the Emergency Care Journal in 2016, Chang and co-authors found that potentially more than half of deaths in low and middle income countries might be avoided with the implementation of effective emergency care systems. So this is why it's really important to develop these systems and think about it from a systems approach rather than the individual siloed approaches from, like EMS, specific specialties, or even those siloed disease processes. And that's too, again, why I would argue that emergency medicine is kind of in a unique position to lead that development. And this really is not just true in low and middle income countries, but in all countries. And as we know very intimately right now, emergency care systems are needed more than ever, given COVID-19, Ebola, and probably the next pathogen that is unfortunately likely to come down the pipeline. And people are really beginning to realize this kind of systems level approach and the importance of focus on emergency care. So we have seen a chapter most recently in the DCP3, the Disease Control Priorities 3 on emergency care. At the WHO at the World Health Assembly has passed several resolutions over the last couple of years on emergency care, most notably this landmark resolution in 2019. So there's progress being made. People are really realizing the importance of emergency care systems and the need to implement them as systems in order to reduce morbidity and mortality. But we still do have a little bit of a ways to go. And just to further emphasize my point with one more bit of evidence, just thinking about the kind of the sustainable development goals. I've listed here just a few of them, but as you can see, many of them cannot really be realized without thinking about emergency medicine and effective emergency care systems. So I hope that has kind of advocated a bit for my point in thinking about emergency care systems, thinking about emergency medicine as a specialty and the importance of it in terms of affecting health worldwide. But what do we start with first? Developing an emergency care system in an area is an absolutely enormous task. I would love to, and we would all love to have the appropriate support to be able to tackle this whole system at once on every individual level. But it's not really possible, as we all know, kind of practically in the real world. And so where do we start? We need to start somewhere. Do you start with bystander training? Do you start with a dispatch system, organizing EMS, having ambulances, facility development? What level of facility development? What really matters most? Now, I'm obviously biased and maybe wrong, but I've already kind of talked about this answer, and I just want to emphasize it again. I think, in my opinion, it's developing the specialty of emergency medicine. I think those with emergency medicine training are really at a unique position to be advocates for and leaders in systems-wide initiatives. And I'm really going to focus on physicians because that's, my area of expertise. I'm an emergency medicine physician, but, it's a whole other talk to go down the road of thinking about other levels of training, but those are equally important as well too, and should happen in parallel. So nurses should be trained specifically in emergency care, paramedics, and so on. But, really thinking about physicians in this context, especially worldwide, specifically, they can be leaders in starting off this development and advocating for it, I think. And so, and the program I'm going to talk about today, the certification program in emergency medicine, or Cpem, it's really focused on physicians. Because, one of the biggest barriers as to looking at why these systems haven't developed worldwide is because, in many areas of the world, non-EM specialties still provide emergency care. So again, I believe this is the first step to developing systems. Providers in country really know their systems, and providing them the foundation in emergency medicine, in emergency care principles, if you're talking about training people at different levels, and the leadership and teaching skills to guide that development, that's where all the other components will then fall into place. And so again, that's what I focused on. That's what we're going to focus on talking about today with Cpem. But how do you first get started with this? How do you get started in this work? How do you get it going? And I think the answer to that is first finding the right partner. And how do you select the right partner? In my case, they really selected me. And I think it's really thinking about mutual selection, having people come together with shared goals, shared ideals, shared work ethics, and the way to approach this task kind of with a systems level approach. In global EM, global emergency medicine, global emergency care, as in many fields, it's the networking and making those crucial connections that often allows people to find the right fit, like two puzzle pieces coming together to help build something. And that's really how my partners in Pakistan and I came together to initially build the Cpem program. They came to me with the facts and figures that Dr. Ghazanfar Salim is gonna present in this next video that I'm gonna show. And through multiple meetings, open lines of communication, and the development of shared goals, objectives, and most importantly, equal investment and work in the program, we developed Cpem. So now let me present Dr. Ghazanfar on the state of emergency medicine in Pakistan, the development of Cpem, and kind of the experiences and lessons learned from that side.
Good morning. My name is Dr. Sayyid Ghazanfar Salim, and I did my fellowship in internal medicine in 2014 from the College of Physicians and Surgeons of Pakistan. Since then, I have been working at Indus Hospital Health Network, initially joined as a consultant and now working as a chair of the emergency medicine service line. I'm also chairing the task force responsible for building the capacity of doctors working at 11 other networks emergency department. I am also one of the founding members of Pakistan Society of Emergency Medicine, and my area of interest and passion with regards to the medicine is the development of emergency care services. On that note today, I will be talking about the dire need of emergency medicine training in Pakistan. Disclaimer: before I begin, I just wanted to put out a no conflict of interest disclaimer. So where I live, I have been living in Pakistan for all my life. Pakistan is a vibrant country. It's home to a plethora of many different cultures, languages, and tradition. From north to south, the landscape changes completely from some of the most formidable mountains in the world to pristine, white sandy beaches. It's a big country with an even bigger population, almost 200 million, 220 million to be precise. With that big of a family, you can imagine how lively things can get over here. Where I work, so I have been working at Indus Hospital and Health Network since 2014. The Indus Hospital is a 331 bed state-of-the-art tertiary care center providing free of cost quality care with dignity. It is set on 20 acres of land in the heart of a major industrial area of one of the biggest cities of Pakistan, that is Karachi. Underprivileged patients come to the facility from all four corners of the country and beyond. The Indus Hospital is free of any political, sectarian, or ethnic association and provides care to people of all religious, ethnic, and social backgrounds through a system of zakat and donations. A transparent system of accounting and auditing allows donors to see for themselves how their contributions have been utilized. And this hospital is now in an expansion phase, and hopefully in next 2 years, a 1,500 bed state-of-the-art facility would be started. At present, Indus Hospital's emergency department is a 35-bed emergency, including 4 resuscitation beds, and 9 beds are also dedicated to the pediatrics, and 5 beds are dedicated to pediatric oncology patients. On an average, we see 500 to 700 patients per day. That is around after every 2 minutes or 3 minutes, there is a new patient coming to the emergency department. Presenting challenges in ensuring smooth patient flow, prioritization of those in greatest need, and provision of standard of care is at most importance. So coming back to the topic of emergency medicine in Pakistan, here is the bigger picture. Like I said earlier, Pakistan is home to well over 220 million people. To be precise, there are 184,711 registered doctors in the country. That is around 9.7 doctors per 10,000 people. Out of these doctors, there are just 15 doctors that are locally trained in fellowship program of emergency medicine from Pakistan. So you can do the maths. So to further break down the situation, here are a few more facts and figures. If we want every emergency patient to be seen by a trained emergency physician in Pakistan, it needs 12,000 emergency physicians, or a more realistic picture would be around close to 20 to 30,000 emergency physicians. Like I said earlier, the number is very minimalistic. Only about, like, this fellowship program in emergency medicine started almost 2 decades ago. So not enough locally trained doctors in Pakistan. And there are almost 100 to 150 doctors that are in training programs throughout the country. So we need to graduate 1,000 FCPS in emergency medicine every year for 20 years to fulfill the demand of 20 to 30,000 emergency physicians. So situation is emergent, and like I said, it is an emergency. Before we delve further into tackling the problem, let's briefly touch upon why we are at this stage. Primarily, it is because there is a lack of training opportunities. With fewer opportunities available, how can you expect to produce more trainees? Secondly, it's because of an unfamiliarity with the concept. With all this in mind, we have to focus on educating students at medical colleges from the very beginning about the specialty. Create faculty and consultant positions who the above mentioned can look towards as mentors and sources of inspiration. And lastly, we need to increase the number of trainers available with adequate skill and expertise. So, certification program in emergency medicine is an year-long course that was developed by emergency medicine professionals at Indus Hospital and Health Network, Karachi, and now led by the faculty at UPenn Philadelphia. In a short span of time, physicians working in emergency departments are provided with the essential knowledge and skills needed to provide proper emergency care. And this program has also shown improvement in learning outcomes. And first, the learning outcome data from the first cohort was published at American Academy of Emergency Medicine Education and Training Journal. That showed a significant improvement in the learning outcomes as well. So what are the goals of the program? To encourage interest and participation in the knowledge of the practice of emergency medicine, to improve the emergency care of patients, and to provide clinical training to serve as a foundation for a career in the practice of emergency care, and to pass along that knowledge to subsequent trainees, and to indulge emergency doctors to adapt this field as their future career and join the fellowship training program that is the most important program in Pakistan. Initially, the candidates who would attend all sessions in person. This, however, dramatically changed with the pandemic as COVID happened. The program in its current state inculcates a hybrid model whereby the trainees attend weekly online learning sessions and every 4 months take part in in-person skills and procedural training. The third cohort has also incorporated candidates from Bangladesh as well. So the program has graduated 43 trainees in total over 2 batches. As of 2021 and 2022, the program is in its third cohort. For the first 2 cohorts, the program was funded by the corporate sector. Currently and in the past, it has always been funded by the philanthropic contributions of individual donors. So here are some of the photographs of the graduation ceremony of our first cohort. On the right is a photograph of our CEO, Professor Abdul Bari Khan, and on the left is a photograph of our graduates. And here are photographs from our in-person training session where Cpem candidates are provided with adequate skills and expertise to deal the patients within the emergency department. Over the span of 3 years, we have had our fair share of challenges. Conducting classes weekly online across 3 different time zones is one of the challenges. We have to frequently be flexible and just adjust our timings because of the daylight savings and in-person visits. Recruitment, interest development, tailoring curriculum every 1 year according to everyone's need. Having the session face to face for first 2 years proved to be more costly, hence making the current day hybrid model more financially feasible. Upon feedback after the first cohort, we learned that the curriculum needed to be revised and be made more contextual. Lastly, but not least, the biggest challenge is to stay consistent and maintain the quality of training from year to year. The program has enabled us to collaborate with more institutes to reach smaller centers and identify centers from the later to further branch out to create a network. The course created better interspecialty understanding, enabled harmony in the emergency department to flourish. Networking improved between different hospitals and other parts of the country. We saw this firsthand during the COVID-19 pandemic when we have to pool out all the resources of the patient that are coming in the emergency department. And we achieved that by creating a safe networking model. And that was also published in the Pakistan Journal of Medical Sciences. So, to collaborate with more institutes, to reach smaller centers, and to identify centers from the later that can further branch out to smaller institutions, hence creating a model of intermingling nucleuses, collaborating and flourishing together. To expand the program internationally to nearby countries in the dire need of emergency medicine, training, and services. Thank you for your time and have a good day, everyone.
Great. Thank you so much, Dr. Ghazanfar, for that, that overview of the need for emergency medicine in Pakistan, where we're at right now, how the program developed, and where we're headed. So I'm just going to reiterate just a little bit of what Dr. Ghazanfar said, but expand on some of the details a little bit more, just to give you a better sense of the program, and to talk a little bit more for those of you interested in education, some of the actual on the ground strategies, and as well as virtual strategies we've used to give you some tips in terms of thinking about working in this space, as well as to talk about some of the lessons learned from my end of things as well. So again, the certification program in emergency medicine, or Cpem, is a medium duration. So when we're talking about training programs, for medium durations, we're talking about like 1 to 2 year programs rather than full residency programs that are, 3, 4, or 5 years long or more. And it's 1 year long, 12 blocks in emergency medicine. And it's really designed to give a mini residency program in 1 year. And what we did when we came together is, really build this from scratch in terms of thinking about it. It was an amazing process of learning and applying educational theory and techniques, and then really building and launching the curriculum from scratch, although using educational materials and experiences from other programs similar to this in other countries. And the program is really designed for medical officers, so individuals who have gone through their initial medical school training and maybe have a year or two experience in emergency medicine, but no formal training in emergency medicine. But it has included individuals at different levels in their training, individuals who have actually gone through specialty training in other specialties, but are now interested in emergency medicine. And we've even included a couple of residents from residency programs to kind of augment their residency training as well. Because as Dr. Ghazanfar mentioned, residency programs have been present in Pakistan for about the last 10 to 15 years. There are about 13, I think, across the country now, and the residency program there is 5 years long. So this is why this 1 year program is so crucial. And initially, when we designed it, the program included individuals from the Indus Hospital and Health Network, but then also hospitals across Karachi. So we had our Cpem-C cohort, or Cpem clinical cohort, which were people from the Indus Hospital and Health Network, and Cpem-D, or Cpem didactic, individuals that would come into the hospital once a week for those educational sessions. And the reason for doing this was for networking and collaboration. So it's included in our objectives. So first of all, as Dr. Ghazanfar said, really to improve emergency care delivery, give people the skills needed to really operate in this space. to develop collaborations and foster support for the development of the system. So get people talking with each other, organically build the system, the network system throughout the city. And then by no means was this designed to supersede the formal specialization mechanism intact in the country. It's really to encourage people to go on then to obtain specialization and really in the meantime improve job satisfaction, wellness, and employee retention. Really show people that this is a career path that they should get involved in and be interested in just because of the need of the hour in the country. And then the way that the program was designed, as you can see here, the kind of the example schedule, 12 blocks really separated out by topic or organ system. And then each block itself is progressive. So it really moves from acquisition of knowledge and things like didactics and really kind of thinking about really just obtaining information to start off with, and then it progresses to application of concepts through multimodal learning. So everything from didactics and lectures, as I mentioned, to workshops, simulation, journal clubs, and so on. And it's really designed to, as I mentioned, to just have individuals share their diverse experiences too from the different levels and different institutions across the city. And then now the different institutions involved in the program, as Dr. Ghazanfar mentioned, we've expanded to Bangladesh. And then also within Pakistan, we've included individuals from across the Indus Hospital and Health Network, which expands throughout the country. So we've got people coming in from all over for the program. And in the past, we had visiting faculty on the ground all year long to teach each block. But now training is mostly online with some intensive hands-on training about every 4 months to do those workshops as the pandemic has allowed. And so for those of you interested in education, let me briefly kind of go through some of our the features of our program. So as mentioned, we initially designed the program to be delivered in person, and we've now transitioned to mostly virtual learning. But as we know, training in emergency care or any kind of medical training can't be entirely substituted for remote learning. There has to be some hands-on component. And so we've strategically placed concentrated sessions throughout, including simulation, procedural training, ultrasound training, and continued bedside mentorship and talking through cases throughout the year. And sometimes this has been with faculty really on the ground in person, and other times with the remote support of local faculty. And we've always tried to make it so that our faculty to participant ratios are quite small to allow for more intimate training. And then throughout this, throughout the program, the participants do keep a log of procedures and ultrasounds, and for actually being able to do procedures in their clinical setting, they must conform to their institutional credentialing rules and procedures. For those of you more interested in thinking about virtual learning, now that things have really transitioned to virtual throughout the pandemic, just to give you some of the resources that we've used that we found really helpful. So just thinking about overall organization tools for the course, we use things like Dropbox, Google Classroom, and Google Drive. As mentioned, we really want to try to keep things as interactive as possible. So we use things like Zoom for the main sessions, but then programs such as Poll Everywhere, Kahoot, during sessions to try to keep things really interactive. We use WhatsApp in an asynchronous way. You can see here a screenshot of we run these asynchronous cases every once in a while to just try to keep people engaged. People talk about their interesting cases just to provide learning when we're not doing the weekly sessions. We do take attendance for the program. So one of the requirements of the program is 70% attendance. And the way that we do that is we have people fill out Google Forms for every session that they attend. That helps them log their attendance, but then we have a couple questions for each of those sessions to give us feedback so that we can more dynamically update the program and then incorporate that feedback into the next iteration of the program. And then when we do have recorded lectures that we present in an asynchronous way, we've incorporated Edpuzzle, which really embeds multiple choice questions throughout the lecture. So we ensure that people watch the lectures because they have to answer the questions, but then keeps people engaged in those those less interactive didactic sessions or recorded lectures. For evaluation, we use Socrative, which is for a written examination, Zoom Rooms for oral examination, and things like REDCap as well for any other surveys. So this really, keeps people engaged, helps to build redundancy into the curriculum, and then helps kind of navigate some of those time zone differences, sometimes connectivity issues, because people have multiple ways to connect and be engaged in the program. And then in case they miss a session, they're able to engage with the material and make it up in other ways. And just to talk a little bit more about some of the simulation and small group strategies. With this, we do a lot of simulation in small groups. So this really helps keep people engaged. And then we know that those we teach will be building up kind of local and regional emergency care systems. And so allowing for these simulations in small groups, we allow individuals to talk together from their different institutions and allow them to share experiences to just organically help develop that in the background. And so with simulation, can be in person, but also virtual. We use both low fidelity models and high fidelity models. We incorporate live models, volunteers, moulage, real equipment that people use. So, oftentimes our international faculty are from all over the world using different types of equipment. We try to use more local and contextual appropriate equipment as much as possible. We use separate procedural models, images and videos, vital sign simulators. All of these can really enhance the simulation experience and then can help us with formal debriefing sessions after each scenario. And then these type of scenarios and multi-patient scenarios, tabletop exercises can really help trainees develop skills, triage, time management, leadership, and communication. And especially these tabletop exercises, they help develop teamwork and communication skills. And these are really well suited for multidisciplinary teams that not only help build up emergency medicine as a specialty within the system itself, kind of bring in other specialties and build up the reputation of emergency medicine in a healthcare system, but then also again helps develop those collaborations across institutions and kind of organically helps you build a network. We also engage in PBL or problem-based learning, CBL case-based learning, and TBL team-based learning. So both in simulation as well as in small group discussions. And then, as I mentioned, we're doing a lot of this remotely now too. There's a lot of resources out there in terms of how to build up a simulation via PowerPoint, how to do these kinds of things on video conferencing using Google Slides. And a lot of innovations in the last couple of years has allowed for all of this to happen virtually. And you could do a lot of really interesting stuff with virtual simulation. So if you have any interest in that, let me know. And then we do use an app that was specifically developed for emergency medicine called Full Code, that it's a way of doing virtual simulation as well. And then, as I mentioned, given challenges with time zone differences, work schedules, differences in learning styles, we all of these are adult learners. We also engage in asynchronous learning. So as I mentioned, we record lectures, but so much of what we do when we build in a curriculum really focuses on that formal learning environment, and we fail to address everything else that trainees have access to. And so especially, in medical education today, trainees have access to an almost unlimited number of resources, everything from books and articles to podcasts, question banks, blogs, Twitter, videos, online medical simulation apps, and so on. And so, this really does allow trainees to pick resources most tailored to their learning style and pace, but they need some guidance. And so we help, we provide some advice on some of the high yield emergency care and emergency medicine resources out there. So I hope that has provided a little bit more of an overview of the program as well as some details, especially for those of you interested in doing this kind of work in education and training. And so if you have any more specific questions on that sort of stuff, I'm happy to answer that and talk about the nitty-gritty of how we practically implement the program. But let's go a little bit into how the program's been doing. How do we measure success? And then I'll talk a little bit more about how what we're looking forward to in terms of the future and some of the lessons learned. So program successes. So let's talk about some of the educational outcomes first, because those are probably the most easy to talk about and easiest to measure in this field. So talk about exam scores and retention and things like that. So over the first couple of years, we've seen about 75 to 80% retention in the program, which is amazing with these adult learners. And it's important to note that on a whole, people for the reasons that people have left the program have really been for factors outside of the program, such as immigration. And then specifically when looking at learner outcomes, the graph on the right of the slide shows the results of this from a set of 50 matched questions that we give both as a pretest and then incorporate throughout the final exam. And as you can see in the 2 years of the program, or in the first 2 years of the program where we have the full information, all groups significantly improved their scores. And I think particularly this last year, this was likely due to our dynamic process of soliciting and incorporating feedback to improve it. And as I mentioned, the two aspects of the program, this is separated out by Cpem-D and Cpem-C, the folks outside of the Indus Hospital and Health Network, and Cpem-C, the folks inside. So that's the difference between the graphs there. And then, looking at this overall, the test scores improved about 15 to 16%. And this really is quite impressive. We're very proud of this because our examinations are written in English. The course is primarily conducted in English. All of the medical education there is primarily in English as well too. And so just thinking about that challenge, but then our questions are really American Board of Emergency Medicine style type questions. So for individuals who have gone through a full residency program, and we do these oral cases as well too that are very similar to the American Board of Emergency Medicine board style oral exam. And so, having this type of improvement after a one-year program is really exciting. We've also seen satisfaction with the program when we've looked at feedback on both individual sessions and the program as a whole. And then individuals as well have talked about their improvement in their confidence and their excitement about the field as a whole. And then we also check for clinical scores from supervisors at each of the institutions, and we've seen improved clinical scores by supervising faculty after the program. So overall, very positive learning outcomes. And as Dr. Gazanfar mentioned, we did publish these results, at least from the first year of training, in Academic Emergency Medicine Education and Training. But how else do you measure success? So not just learning outcomes. We need to think about clinical outcomes and the clinical impact of this program as well, which isn't often done from educational programs. And something we have actually done. And actually there's a paper under review right now at BMJ Open on the clinical outcomes from the program. But just to give you a sneak peek on that, we saw overall positive changes in clinical metrics, including mortality, after the implementation of the program. Other ways of measuring success. So as was mentioned as one of our goals, employee retention, we've definitely seen that at the Indus Hospital and Health Network. We've seen the development of networks as well as promotion of individuals who have been involved in the program. So for example, thinking about promotion, Dr. Gazanfar initially started out as the program director, and he's now progressed up to being the chair of emergency care services throughout the entire hospital, Indus Hospital and Health Network across Karachi. The graduates of the program, a couple of the graduates are now helping to lead the residency program at the Indus Hospital and Health Network, and we've seen graduates from other institutions now put in positions of leadership in their departments because they're the only ones with any sort of emergency medicine training there. And then these networks have developed as well too. The graduates stay in touch, especially during COVID. They're developed kind of a referral network with even a standardized form in terms of trying to get patients beds in different hospitals. And even when we're thinking about trauma and other disease processes, because there isn't, a formal EMTALA or a formal transfer process of patients from hospital to hospital. Here in the US, you have to ensure that the next hospital has the appropriate resources and space for a patient before you transfer them. There, it's more like, we don't have space. Here's the information of what we did. Good luck kind of finding the next hospital. We think you need to go to this place because this is where the specialists are, but you kind of have to get there mostly on your own unless it's a very critical patient that does need a transport arranged. So it's exciting to see the kind of organic networks that have developed from this. And then as Dr. Gazanfar mentioned, thinking about research and publications, not only outcomes from the program itself, the educational outcomes, the clinical outcomes, but as he was mentioning, research on COVID-19, we've looked at patient satisfaction and considerations of privacy. We've looked at trauma. And so graduates from the program, faculty involved in the program have collaborated on research and published several papers as a result of this. So it's been really exciting just to see, how emergency care has developed in the region as one side effect of this program, and it's really been an exciting project to work with in terms of the partners that I've been working with. And so let's talk a little bit about the lessons learned from the partnership itself. So I think I've alluded to some of them, but let's just go into a few of them a little more in depth. So many of these are in line with what you see in the literature regarding effective global health partnerships. So first of all, you want a good alignment of vision and goals regarding any program. You need a strategic plan. You need to think about SMART goals. And this is what we're doing with the program. Every year we kind of sit down and talk about what does the program look like? How do we need to change it based on the feedback? And we're constantly challenging ourselves, questioning ourselves, is this program still viable? Does it still work? Is it still appropriate right now in this context? And we've all kind of sat down and talked about it and said, when this when it's no longer useful, we're going to stop it. I mean, the goal of this program itself is to really work itself out of a job. We want the specialty to develop in a formal way. And so we've all kind of recognized this with the program. And so everyone's kind of on the same page and on board with that. So that's, I think, what's really made this partnership effective, is just kind of recognizing that up front. Next, kind of thinking about stakeholders, governance, management. So for better or worse, we've really tried to keep this program as independent, I would say, as possible, with ownership primarily really resting with the faculty at the Indus Hospital and Health Network and myself. You know, I would say if we had to give it a home, it's the Indus Hospital and Health Network, but we've really tried to kind of keep it independent so that no one institution formally owns it and it can't be moved anywhere else or expanded anywhere else. So for example, when I helped start this program, I was at a different institution. If we had really housed the program there, now that I'm here at Penn, we wouldn't have been able to really move it, or I wouldn't have still been able to be involved with it. And so I think that's been helpful, but then it you know, it's allowed us to be more flexible and adaptable, but it does make governance a little bit less clear. And so one way to really mitigate this is to just ensure transparency as to what this program is and how it is, quote unquote, owned and implemented. And then just, you know, making sure communication is very open and transparent. And I think that's one of the first underlying themes when thinking about all these lessons, and that's communication. When the program is running, we really communicate almost daily and really identified clear roles in terms of faculty, who's involved as faculty, who's involved in coordination, really just to keep everything as transparent as possible. It does require more work and frequent updates and sometimes frequent reminders. And this has been even more challenging in the last year, given the expansion to Bangladesh, as you can imagine, with the history between the two countries. But it has allowed us to remain flexible and adaptable and really focus on the trainees and the learners in the program. And it's really incredibly important in any partnership to ensure to identify, involve, and or recognize all stakeholders, which can be challenging to identify, but really allowing the time to identifying them, ensure you're giving credit and or acknowledgement where it's due and oftentimes expected. That really helps ensure transparency and communication as well too about the program in terms of how it operates and what it's doing within kind of the larger context in the country. So not only kind of people intimately involved in the program having that communication, but just thinking about all potential stakeholders. And that does include, you know, people who just have been involved in this space in the past, and making sure you're going around and having all those meetings and recognizing kind of the people who have really had efforts in this space in the past or are currently working in that space now. And just really ensuring transparency, as I mentioned, and regular reporting on the program and what the outcomes are. And so to that point, kind of the second aspect of kind of the underlying lesson would be time. So in addition to communication time, all of this really takes time. And then subsequently, you need funding for that as well too. So everything in this field really does take longer than you think, from stakeholder meetings to developing educational content. And I'm sure most of you have prepared, or if not all of you have prepared a talk at some point, so you know what I'm talking about in terms of the amount of time it takes to develop that, and especially too in terms of developing educational content. There's many formulas out there as to, you know, how much time it takes, you know, 5 hours for 1 hour, 10 hours for 1 hour, things like that. You know, there are a lot of resources out there. You don't need to reinvent the wheel in these type of programs. So take advantage of those resources, the experience of people out there to help optimize your time, but know that, you know, programs and resources can't be cut and pasted from one place to another, and there needs to be adaptation, flexibility, and all of that. So it does need to take time. You do need to take the appropriate time to develop those resources and develop those relationships. And then to that point, if you need time, you need funding. With the increased international recognition of the importance of emergency care systems, there is more funding popping up for this type of work, but it still is a greatly neglected area. So think outside the box a little bit in this field. If you are involved in this type of field, look for foundation funding as well as funding from sources in country. There's often a lot of organizations such as banks or other industries or other charitable foundations who are just looking for ways to contribute in this type of space. So look there, and that's where we really got the funding to start up this program from in-country sources. Now we're getting the funding mainly through the educational organizations that are involved in the program, but they're still kind of ultimately getting that from foundational funding and donations, such as specifically with the example of the Indus Hospital and Health Network. It primarily runs on that type of funding. This is an area, as with anything in education, where you're likely going to do a lot of unsupported work if you're working in this space. But try to optimize that time as best as possible, make it most efficient, and then do realize the importance of funding and thinking about that, because this type of work really isn't fully respected unless there is a price attached to it. So we do have fees attached to the course. So you think about engagement and investment in a program. You really need to have, individuals need to have, quote, skin in the game in order to really respect it and be invested. And so ensuring that you do have some fees attached to this type of program. We've learned that over the course of implementing it is really helps keep people engaged. So people really are more likely to value, respect, and push for the success of things in which they're invested in. So make sure you tailor it to the setting. Make sure you've done your research in terms of, what those prices need to be, which is what we have learned over the course of this, of implementing this course. But that's definitely something that needs to be implemented. And then finally, we talk a lot now about decolonizing global health, and that's really important to think about. You really need to continuously evaluate power dynamics, flow and allocation of resources, and things like that. No partnerships are ever entirely equal. You know that incentives in these sort of programs vary widely, but approaching them critically and with humility, and ensuring those open communication lines, understanding, when you make mistakes, we're all going to make mistakes in this type of work, and just having those open lines of communication and the underlying relationship, you all understand that you're going to do something wrong at some point, and that helps help you just talk through that process, overcome that process, and move forward from there. And so keeping the eye on the shared goals and vision will help overcome any of those type of challenges. So I think our continuous WhatsApp chats have really helped overcome any sort of issues regarding that. But just keep that in mind in terms of doing this type of work. So what are the steps forward with the program? I'll talk about this briefly, and then we'll have a bit of time for questions, I think. So again, we're finishing up the third cohort right now. We'll finish that at the end of June, and we plan to put the program on hold instead of starting up right again in July. We're going to put it on hold and start the next cohort in January 2023, and we'll be working again in both Pakistan and Bangladesh. In the meantime, we plan to develop and run a faculty and leadership development course this fall, try to engage graduates from the program, especially those in positions of leadership now at different institutions, to be local faculty leaders for the program. When we're talking about, sustainability of this program, it can't just be led by the couple faculty really at the top anymore. We need to think about expansion as well as local faculty development. So that's what we're going to be working on this fall, developing a course for that, implementing that, and then hopefully starting back up again with an even expanded cohort in January. So we're aiming for about 100 participants across 2 countries. As of this June, we'll probably have graduated about 75 in total from the program over 3 years. And then, as you can imagine, to do this, we need additional funding. So as I mentioned, we started off with foundational funding, funding through the educational institutions, but we're going to be looking for kind of larger grants and foundational funding to help support this now on a larger scale and the international scale as well. And then continue to be committed to development of the system as a whole. So continue to support local research, thinking about additional kind of graduate classes or continuing medical education classes for graduates of the program. And then we're also looking to implement the WHO ICRC basic emergency care course to think about training in emergency care at different levels of the healthcare system. So this is a 1-week course that's designed for anyone at any level, but mostly non-physicians, and especially individuals at critical access points in terms of very basic emergency care concepts on how do you stabilize someone and then get them to a higher level of care. And so we're working on implementing that as well too. And in all of this, working with the graduates from the program, keeping them engaged, and really just continuing to build up the system there. And also now in Bangladesh, where EM is not a recognized specialty. So we're even starting from further back there, and we're hoping that all of this work helps to get it recognized as a specialty there. So I hope in talking about my experiences with the Cpem program and in hearing from our partners in Pakistan, that's giving you a better sense on what we do. And then just thinking about one example of our partnership and lessons we've learned from that. A huge thank you to our partners in Pakistan, specifically Doctors Ghazanfar Salim, Saima Ali, Adil Khatri, Sama Mukhtar, and Bilal Hassan, the leadership at the Indus Hospital and Health Network, and our partners in Bangladesh as well too. And then again, to the Center for Global Health here for this opportunity and support. So it's really been an honor to be here with you all virtually today and talk with you about this work. And I'm happy to take any questions now. And Dr. Ghazanfar said he's happy to take questions as well. I provided his email and his Twitter here also. So thank you so much.
Thank you. That was a very insightful talk and presentation, and I really hadn't known much about what the specifics and details of your work, but wow, to summarize it in one word. But thank you again very much for your presentation. And with that, I'll turn it over to our audience. Feel free to enter any questions that you have either in the chat or Q&A box. And if you'd like to ask your question directly to Dr. Robarczek, just raise your hand and I'll go ahead and unmute your mic. So while we're waiting for questions from the audience, I did have a question of my own. You talked a lot about sustainability and making that ownership upon your partners there in Pakistan and Bangladesh. I'm curious though as to what involvement either the Ministry of Health or Education had or potentially will have in the future to kind of expand these specialties, at least in the case in Bangladesh, getting it recognized and promoting it more so in the medical education curricula in Pakistan.
Yeah, no, that's a great question. So it's very different in both the countries. So let me talk about them individually. So in Pakistan, because emergency medicine is already a recognized specialty, there are fellowship programs or residency programs for it. There will not be any recognition of this program on the national level. We actually did talk about it at the beginning, because obviously, whenever you're implementing something like this, you want it to think about it through kind of the highest level of certification and recognition. And we did have conversations about that because there has been this sort of model has been incorporated with other specialties, thinking about like a 1 to 2 year master's level type program. So we've talked about like, could we adapt this to be a formal master's level type program through the Ministry of Health, thinking about the licensing societies in Pakistan and stuff. But because of where emergency medicine is as a specialty in Pakistan, that's just not going to be possible. And so we've kind of left it at the certification level there. Specifically in keeping it mainly housed in the Indus Hospital and Health Network, we've gotten buy-in and collaboration from the leadership there to ensure kind of promotional tracks for the people that go through it as well. And then, kind of organically, we've seen, even other institutions providing that promotion for folks as well too, just given the certification of the program and who is sponsoring the program itself. So that's Pakistan. And then Bangladesh, actually, because it's not a recognized specialty, there's actually conversations happening right now at the higher level using this program as a springboard to thinking about either that kind of master's level type programming, and then using this as an example model curriculum to start the specialty at residency. So there's been some development of some curricula talks at the government level on how to incorporate this kind of at that type of level there. So that's where we're at in Bangladesh.
Okay, thank you.
Yeah.
Looks like we have a question in the chat from Angel. He asks, what was the rationale for choosing a year-long program versus any other time frame?
Yeah, so we went back and forth and kind of talked about this a lot. We wanted something that would allow us to have somewhat comprehensive training. So we wanted it to be a little bit longer, so more than just like a week or even 6 months. There was actually kind of a 6-month program that was implemented in Haiti a couple of years back as well too. But we found when we were talking about having the conversations with our partners in Pakistan, what's the optimal time? If you start to get longer than a year, it gets a little bit more of a heavy lift for people to go through it. And then the folks who maybe haven't gone through residency program for various life reasons, that 5-year-long residency program, or may not be as interested in the program if you make it too long. So we settled on kind of going back and forth and just looking at the content and what we wanted to include, that a year seemed to be the optimal time. So.
Thank you for that. And I believe Glenn has a question. He has his hand raised.
Yeah, you hear me?
Yes.
Yes.
Yeah, so first of all, thank you. And a brief apology, which is I had a meeting that ran over, so I missed the very beginning of the talk. So I got to go back and look at your slides. But I have a couple of questions. I'll handle them one at a time, and hopefully we'll have enough time, because I certainly don't want to discourage others. So the first one overlaps actually with Angel's question, which is how do you decide, and how did you go through deciding what content should be included? I mean, because you've gone through an incredibly rigorous training program. How did you just come through the process of determining, what are we going to be satisfied with, for lack of a better way of saying it, in terms of the knowledge that you want the participants to acquire?
Yeah, that's a great question. That was just a lot of conversations, a lot of back and forth. So we started, as I mentioned, don't reinvent the wheel. There are examples out there. So looking at other programs that have been implemented in other countries, and what content they've incorporated, looking at other curricula that are out there, like AFEM, the African Federation of Emergency Medicine, has a lot of emergency medicine content out there, a lot of PowerPoint presentations, curriculum. IFEM, the International Federation for Emergency Medicine, has kind of standard objectives, looking at just the examples from American residency programs and the milestones that people go through. So kind of bringing that all together, and then talking with our partners there in terms of what they wanted to see from the program, and then just putting something down on paper and then editing it from there. And then also several trips to the country in terms of looking at the context. What kind of resources do they have available there? Do we need to be talking about CT scanners or not? Do we need to be talking about like sending someone to the cath lab after a heart attack and MI for PCI? Like, what resources are there? Should we even include this content or not? And so recognizing that we are including people from different institutions, so we've kind of been a little bit more liberal, leaving some information in case they are exposed to it. But we started with something, we optimized it as best as we could before actually implementing it, and then that's why we've incorporated this aspect of continuous feedback, so that we can get that information back then from the participants. This was not helpful at all. We don't see this at all. Like, take this out next year. And so that's what we just keep doing as we incorporate more and more people. So yeah.
Oh, that's great. Thanks. And I ask just as the broad curiosity, but also because, and you and I have chatted about this briefly, and I think we're meeting next week as well. So I want to follow up on this one, but we're seeing the need in many, many countries for, I'm going to call it, versions of certification programs in almost every medical subspecialty, frankly, because most places certainly don't have fellowships. Oftentimes they don't even have residencies in the way we would think about it. So, and again, I apologize because you might have touched on this at the beginning. If we were to take, oncology, cardiology, pulmonary, just start plugging in a bunch of, medical subspecialties, do they plug into this model? I mean, I understand, of course, the content is going to be, well, actually, some of it's going to overlap, certainly the pulmonary and cardiology side with you guys. But content aside, is what you've developed. So if I was going to start, as I have to start with other colleagues, certification programs in other countries is a good way to start that, by actually walking through your model with those individuals, saying, hey, is this a great way to do it? If you plug in your knowledge in, fill in the subspecialty, or are there too many differences between the medical fields?
Yeah, that's a great question. Yes and no, maybe. I think it probably will depend on the specialty. So we have seen this happen in other specialties. For example, OBGYN, I believe in Pakistan is one example where they've implemented like a master's level type program. I think it's like 2 years long there. So I think in certain specialties, this type of model lends itself more easily to that. I think it's just it would be a critical process to really see, and then try it once to see if that would work. But I think overall, just knowing the limitations of the what individuals trained in these certifications can and can't do, and really having that clear and worked out with ministries of health, certifying bodies, things like that. As long as that's open, transparent, and there's been, really good process ahead of time to work with individuals who are in education, who understand educational theory, how these training programs work, to really optimize that and then plug in the right content, it could potentially work. But I think it's going to be like, specialty by specialty basis, and is really going to take a lot of work on the ground figuring that out. So
yeah. You encounter individuals who then say, even though you're doing this all there, I want to come to Penn, and how do you must hear that at some point, right?
What do you mean in terms of coming to Penn?
Did you have pressure in the beginning to deliver some of this here and actually bring all or some component of people participating to Penn, or up in Boston previously?
Not really, actually. People really wanted to do the training there in the context that they're in terms of that. I mean, in terms of some of the faculty, potentially there was talk about bringing faculty in for further development, which I think is a great initiative. When you think about decolonizing global health and equal exchanges, we're sending people there to teach and all of that, and potentially even sending trainees to also benefit from experiences with this program as well. But I think opening that up, especially for faculty development, maybe not at the trainee level, but faculty development in things like education, simulation training, all of just leadership in emergency medicine, like how to run a department, and thinking about just clinical operations and all of that. I think that is where one, we could help with bilateral exchanges, and two, just help augment the program even more in terms of the training of faculty.
Yeah, and that leads me to my last question. It's the perfect lead into how you're thinking about the faculty development course that you mentioned for the fall, and how much of that is focused on, at least the way you're conceiving of it now. You've still got, you're obviously still planning, but how much you're thinking about the broader concepts about leadership, then leadership in medicine, and then the content areas and that they need to learn in terms of being able to then lead by example. How do you see the breakdown of those three?
Yeah, I think for this course, we're potentially going to be focusing it very narrowly on how to run a Cpem program is going to be a big bulk of this, but also then a little bit more broadly on how to lead a department potentially, or be a leader in an emergency department. But I'd love to expand it further than that and really think about leadership in medicine. And that's where I think then we would need to think about, how could we do bilateral exchanges from that? And that'd be something I'd love to talk about with you next week.
Yeah, so. Please, let's put that on our agenda, because that is another huge need area.
Yes.
Great. Thank you very much, Megan.
No, thank you. Those are great questions.
Thank you. I want to be respectful of everyone's time. It is a little after the hour. If anyone has any last questions, last minute questions, feel free to put them in. If not, I'm sure Megan would be okay with answering questions. She has her email here. Before I let everyone go, I just want to provide a scheduling reminder that next week, next Wednesday, May 25th, we'll have the Center for Global Health's director, Dr. Glenn Galton, joining us, presenting. Again, that time will be from 12 p.m. to 1 p.m. Eastern Standard Time. And with that, thank you again, Megan, for joining us and talking about your partnership.
No, thank you so much. This was a great opportunity. And again, happy to answer any questions anytime. So please email me.
Thank you, and goodbye, everyone.
Bye.